Satyamurthy Aytal, President, IMA, Mangalore.
We be happy. May every one of us see to it that nobody suffer from any pain or sorrow. I do not ask for crown, nor I wish to be in heaven or reborn. I only want to alleviate the suffering of those people who are burning in fire of sorrow.
Professor Dr. Bhaskar Shetty, then Dr. B. Narayan Naik supposed to join us with a short time. Then Dr. Suresh Rao, the director of Mangalore Institute of Oncology. Then Dr. Incoming President-elect, Dr. Ven Gopal, our Secretary, Dr. Sadananda Pujari, State Vice President, Dr. K.R. Kamath, and our Treasurer, Dr. G.K. Bhatt, and dignitaries of the dais, respected senior teachers, senior junior members of IMA Mangalore, invite guests, and family members. So a good evening to every one of you. Today we are having our prestigious Dr. K.R.KINI Memorial Oration, and also followed by general body meeting of our IMA Mangalore branch, wherein the list of the new incoming office bearers would be announced. So, at this juncture, you all know Dr. K.R.KINI, who is the first person to practice here after MBBS in 1920. I think Dr. K.R. Kamath is going to give an introduction about Dr. K.R.KINI. So he is the first person who has started some South Canara Professional Association of Doctors in somewhere around 1930, before the inception of our IMA Mangalore, IMA South Canara branch. So he is the one who felt that always the doctors, if they assemble together and exchange their views, it is better for the patient and also for their profession. So he is the first person. On his name, we have, the IMA Mangalore has started this oration every year. So we are on that juncture now. Here we have with us as chief guest, Dr. Suresh Kudwa. He is our president of KSP, that is Karnataka State Chapter of IMA, and he is something about our Suresh Kudwa is everyone said that he should be brief, so I'll be touching only important points. He had his primary education in Katir, and then MBBS from KMC Manipal, then DCH and MD from Mysore, MMC Mysore. Then he started his pediatric practice in 1984. He has served IMA Karkala branch as well, the state branch, in various capacities, and executed his job properly. He has been awarded many awards. He has received many awards from Rotary Club, JC Lions Club, and other things. An important one is, I think, he is the person who received BC Roy State Award in 2019. So he is with us. And I think he is second time he is visiting as our chief guest, I think. First time he had come installation day, yes. So on behalf of every one of us here, I welcome you, sir, to this August gathering.
Ladies and gentlemen, to welcome the chief guest of today's function, Dr. Suresh Kudwa, President IMA KSB, I call upon Dr. Jerome Pinto, sir, to kindly come forward and welcome Dr. Suresh Kudwa.
We have with us Professor Dr. Bhaskar Shetty, Kailiktere, Molahalli village, he belongs to. And he had his MBBS degree from Hubli, then MS from KMC Mangalore, and he served initially as assistant surgeon government side. He has worked in Kota Primary Health Center, District Hospital, Somarpet, and Government Venlock Hospital. Later he joined KMC Mangalore, and he ascended up in the cadre, became professor, and he became HOD of surgery at Justice K.S. Hegde Medical Academy. And of course, he has trained many of us. He is a teacher of teachers. Many of us here, I think we are his students. So, and he has got many papers, 10 scientific papers and research paper. And then he's one thing I want to like to tell is he is the main person behind having this IMA building here. He is the one who fought with the government and got a land for our construction of this building. Any other additional, I think, introduction. So on behalf of every one of us here, I welcome you, sir.
Call upon Dr. Diwakar Rao, sir, to kindly come forward and welcome Dr. Bhaskar Shetty.
Our guest of honor is Dr. Suresh Rao. So he is my ex-colleague. We worked together in Father Mullah's for many years. So you are a simple person, always smiling. So Dr. Suresh Rao is the chief of Radiation Oncology Department at Mangalore Institute of Oncology, and he is an expert in external beam radiation therapy and brachytherapy. So he has done his MBBS and MS, the MD Radiation Oncology, both from KMC Manipal. Then he has vast experience of working in various premier cancer centers in Europe and USA. And he has the unique distinction of starting 3 radiation oncology centers in the world. One is Salmania Medical Complex, Bahrain, Father Muller Medical College, Mangalore, and Mangalore Institute of Oncology. And one more point about him is he is one of the few radiation oncologists in India to have specialized in stereotactic ablative radiation therapy, a method that helps to eliminate tumors that cannot be removed surgically with minimal side effects. So he is the first doctor to have adopted the stereotactic ablative radiation therapy in Mangalore. And he has, I think, completed about treating, I think, 40,000 of patients he has given radiation therapy. So on behalf of every one of us here, I extend you a warm welcome, sir. And also,
Ladies and gentlemen, on behalf of IMA Mangalore, I call upon Dr. Devdas Rai to kindly come forward and welcome Dr. Suresh Rao.
Dr. Narayan Naik is the president of Kasaragod IMA, and he is, I think, vice president of Kerala State IMA branch, state branch, and he is a pediatrician by profession, and he is vice president of KGMO, Kerala. And so that is about, and he has trained both government and private health care workers, so many are there accomplishments, so I don't want to read all those things. Anyway, he may join us at any time, so I also welcome him to this CME program. And on the other person on the dais are Dr. K.R.KINI.ORATION, our state vice president, and President-elect Dr. Ven Gopal, Treasurer Dr. Sadanand Pujari, and my friend, Secretary Dr. Sadanand Pujari, Treasurer Dr. G.K. Bhatt. So as a formality, I welcome you also to this CME. And then on the dais, on the MC desk, we have Dr. Jatanna. So, and dignitaries of the dais, all the senior and junior members of IMA Mangalore, invited guests, family members, I invite or I welcome each and one of you for this CME. And please be seated and let the proceedings to happen. Jai Hind, Jai Karnataka.
And to acknowledge our grief and to pay respect to the departed soul, I would like audience to kindly rise and observe a minute of silence, please. Ladies and gentlemen, I request everybody to kindly take this. To begin with, today is the memorial oration of the late Dr. K.R.KINI to introduce Dr. K.R.KINI and to give a brief note on his accomplishments. I call upon Dr. K.R. Kamath, Vice President, IMA branch, to kindly come forward and do the honor.
Settled down for his own private practice in Mangalore, South Kannada district in the year of 1923. He was the first MBBS degree holder in this city during that time. He had graduated from Madras Medical College in 1920, joined the government service, married to Ratnabai in 1922, and found it is better to practice of his own. And he served as a general practitioner in the real sense of word. He practiced all branches of medicine successfully. Within a short time, with his dedication, a ready smile at his all the times and affable nature developed into a large clientele. Having his residence and the place of profession at the heart of city Mangalore, he was very busy, and one could see him going to rounds of house visits on a horse-driven jet car starting at 11 a.m. and returning home for lunch at 3 p.m. and he was available for services of all hours of the day during those times and also night. Dr. Kini soon enough to found that doctor's life could be lonesome without company of his fellow professionals, with the object of keeping it up with the high tradition of medical profession, as well as to create a brotherly feeling amongst the members of the profession. With a few like-minded colleagues, he broached the subject of starting a professional association, maybe before the IMA started in this country. And few places, even in Gadag, this has happened with one of the private practitioners there. For the few years, the district medical officers were requested to be the president, and Kini took the unenviable role of secretary and treasurer for the association, not only for the first 8 years and again after 5 years. And though its initial membership was only 20, soon enough doctors from surrounding places like Udupi, Kundapur and Brahmavar, Puttur, Uppinangadi, Karkala, Mudbidre, other places joined here. That's why it was South Kannada branch, and Kini was informed in his, he was informed in all his subjects, and he kept himself up to date. Constant study of medical books and journals. He often contributed to the articles involving his experience to the Journal of Antiseptic of Madras. He worked honorary assistant surgeon in Government Venlock Hospital, Mangalore, for a few years on the surgical side. Kini attended several provincial and all India conferences of Indian Medical Association, and Dr. Kini loved the branch of the association which he was a founder member. He worked hard for the welfare of the association till the last. He died suddenly after a brief illness on 29 September 1954, leaving his wife, 4 sons, 3 daughters, and the vast circle of relatives, friends, and grateful patients. And Dr. C.R. Kamath, his maternal uncle was K.R.KINI, and last year Dr. Achut Kurva called a few of the relatives to here, and some of them in Hubli, if I am not wrong. And in the honor of his inestimable service to the branch, this branch, a portrait of K.R.KINI was unveiled, and also a memorial oration was held every year. That's why we are doing this today in the name of Dr. K.R.KINI, that is Dr. Kulal Raghavendra Kini. Thank you.
Ladies and gentlemen, now we come on to the address by the chief guest, Dr. Suresh Kodwa, President, IMA KSB branch.
Respected President, IMA, Mangalore, Dr. Aita, Secretary, Dr. Sadanand Pujari, Chief Guest, Dr. Bhaskar Shetty, Dr. Suresh Rao, next year's President-elect, Dr. Venugopal, Vice President, Karnataka State Branch, my office bearer, Dr. K.R. Kamath, and your treasurer and my PRO, Dr. G.K. Bhatt, and esteemed members of IMA Bangalore. It gives me a great pleasure to associate with you, that too on the occasion of Dr. K.R.KINI Memorial Oration. As you are told, Dr. K.R.KINI was a founder secretary of this branch, and he has been secretary for 8 years initially, and again maybe few more times. And I am told he is a model family physician. And on this auspicious day, Dr. Shekhar Pujari is going to enlighten us regarding family physicians. What is the role of family physician? Dr. K.R.KINI himself was a model family physician. I think we have to follow him. That is the need of the hour. Friends, all of us knew that family physician has a great role in the management of our patients in the society. The old glory of medical profession was mainly because of these family physicians. At those days, doctors were treated as gods. They were very much respected. However, now the day has come, doctors are highly suspected. And we have to drive out this social thinking, and we have to bring back the glory of family physicians again. No doubt, now this is the era of specialization. We don't have dearth of any doctors. To be frank, in Karnataka state, number of doctors are much more than what WHO expects. We have maybe 1:500 doctors as of now. Every year we are producing around 9,000 doctors in Karnataka itself. And as of now, registration in KMC is 1,65,000 odd. Even some of them have died or gone abroad. Most probably our ratio of patient to doctor is above 1:500. Still, government feels that doctor-patient ratio is less. We need to more. So, many more medical colleges are coming up day by day, and seats are being increased day by day. And recently, in Rajiv Gandhi University, for confirming its seats in PG seats, in one medical college, they have applied for 40 MD medicine, 40 MS general surgery, 25 MD pediatrics, and it's the same, maybe almost 400 PG seats. And with this number of doctors being produced, forget about MBBS, postgraduates, where we are heading to. But still, society is not happy with our medical facilities available. You know that olden days, many of our rich people and politicians used to go abroad for the bypass surgery or organ transplants. Now all that is reverse is happening. People from abroad are coming to India for such treatments. This is all because of the improvements of medical education in India. So because of the MCI which started in 1956 by Dr. B.C. Roy, medical education has tremendously improved. And so much so that recent COVID disaster, it is well managed in our country than in any country of the world. The mortality was to the least in India. Even with vaccinations, the Indian vaccines were later proved to be the best, and we have been the world leaders in vaccinations. So all these developments in India still people are not happy. People feel that medical treatment is costly. So we have to introspect ourselves. At least at IMA level, we should discuss ourselves how to streamline our system. Definitely, things are not really right. But the association like this, association like IMA, and all other associations, we have to introspect ourselves. Friends, this year, and what I feel is, in our profession, what is mainly we are lacking unity. All our modern doctors are divided in different associations. IMA, no doubt, is a mother association, but all other associations like IAP, API, ASI, COPSI. So many of these members of these associations are not members of IMA. So we are not united. So this year, to improve the unity, we have started an idea called FOMA, Federation of Medical Associations. That means all the specialty associations along with IMA will work as federation and at district level, and we plan for the common CMEs, common get-togethers and common socio-medical activities, so that the unity among our association will improve. Definitely, IMA Mangalore has taken a lead in this, because what I am told is, in IMA Mangalore, almost all specialists are members, and majority of the CMEs are sponsored by this specialty organization, and you have consultants association. So I expect this idea has come from Mangalore itself. Finally, IMA Mangalore has done a wonderful work this year. There are very good CME programs, very good medico-social activities. I expect that they will bag many more awards in this IMA State Conference. With this few words, I conclude.
First of all, I thank IMA Mangalore branch for inviting me as guest of honor for today's function. It is a great honor to IMA Kasaragod. For the last 1 year, we IMA Kasaragod branch, we were celebrating our Golden Jubilee year, and we were conducted many socially committed activities, including activities for the benefit of our members. IMA Kerala State Branch is having so many social service schemes to the benefit of our members, including Social Security Scheme 1, 2 and 3. Also we have Professional Protection Scheme, Health Scheme and all. So many of the doctors practicing here in Mangalore are from our place only, Kasaragod only. So a relation between IMA Kasaragod and Mangalore branch, it is the need of the hour. So many issues are there during this era. There is issues related to our medical profession and so many other things. So we have a greater role to play to tackle such issues. We need full support from Mangalore IMA, because actually in Kasaragod we have no tertiary care facility, no medical colleges. So our patients depend on Mangalore hospital. Mainly you IMA doctors, we depend on you, and there will be some issues when we refer some patient to here Mangalore. Some issues will develop, some communication gap will happen sometimes. So our humble request is, as far as possible, try to dilute the situation and take the confidence of the patients as well as the doctors community, so that we have a harmonious relationship between IMA Kasaragod as well as IMA Mangalore, and we want to have a good relationship in future also between IMA Mangalore and IMA Kasaragod, and so in future I think we can conduct some meetings together, so that IMA Kasaragod doctors benefit from the knowledge what Mangalore doctors have, and also reverse from the practical point of view, where when the general practitioner side, from the many of doctors we in Kasaragod, because they are doing lot of great work because of the limited facility available there. So we can have a mutual interaction between the two doctor community, and we have solutions for that issues whenever there is some issues. So first of all, I thank the office bearers for especially Dr. Sadananda Gowda and Aital sir for inviting me for this. Along with me, our secretary Dr. Kasim is there. Dr. Janardhan Naik is the Central Council member. Dr. Jyoti is the gynecologist, General Hospital Kasaragod, my better half. So we, as a team, we came to here to attend this meeting to see how the things are going on here in Mangalore. So we have our Golden Jubilee souvenir here. I request Dr. Kasim to please come, and we'll hand over that souvenir to your branch as a token of appreciation for calling us here.
I request the President, IMA Mangalore, to kindly receive the souvenir from the IMA Kasaragod President.
With these few words, I conclude my speech. Thank you. Thank you.
IMA Kasaragod, who took the trouble to come here and be a part of this CME today, K.R.KINI.ORATION and CME today. We welcome you on behalf of IMA Mangalore. Thank you. Ladies and gentlemen, we have another guest of honor, who is a teacher of teachers, as Dr. Aital sir correctly said. So I call upon Dr. K.R.KINI.ORATION to kindly come forward and address the gathering.
Esteemed President Dr. Satyamurthy Rao, Chief Guest of the evening Dr. Suresh Kudua, Guest of Honor Dr. Suresh Rao, Dr. Narayan Naik, Secretary Sadanand Pujari, Dr. K.R. Kamath, incoming President Dr. Venugopal, Dr. Sankabitlu, and Mercurial Master of Ceremony, Galaxy of my colleagues. At the outset, I thank the office bearers and the members of the IMA Mangalore for inviting me to be guest of honor on this great occasion. IMA is great. We are the people who should be the support or the most important part of the IMA to survive and progress. Unless we are united and have affection and helpful nature to each of others, we cannot tackle the problems that any one of us may face during our professional life. Be honest to your patients, be committed to your work, do hard work, and be morally, you should be upright and very considerative when we charge the patients. The problem starts only when the bill is handed over to the party, and particularly whether it is because of the disease itself, the result is not good. Not necessarily that you have done bad. Under that circumstances, the patient and patient's party are against you. but face it by means of always putting everything in writing on your case sheets, every documentation, a proper documentation, a clear-cut handwriting, and the entries always will save you, and it is most important in all aspects of your future also. Be helpful to your juniors. Do not belittle your colleagues whenever something happens to his patient or when they come for second opinion, and always protect your professional colleague. Be united, be helpful. This building itself is an example of unity and the purpose of common feeling. And unless we are united, we will never succeed. I don't want to take much time. I wish all the youngsters to do well, and your hard work will definitely give you very good returns in your life. Thank you.
Even IMA Mangalore would like to recognize the services rendered by Dr. Suresh Rao, Director MIO Mo Hospital Mangalore, and on behalf of IMA Mangalore, we would like to felicitate him on this occasion. I call upon Dr. Suresh Rao sir to kindly come forward and take his seat on the ceremonial chair. I request the President, the Secretary, the State President, the State Vice President, and all the dignitaries on the dais to kindly come forward and do the honors of felicitating Dr. Suresh Rao, Director, MIO Hospital, Mangalore. And Pujari, the Secretary of Mangalore, has been prompting that Suresh Rao has completed more than 40,000 patients in his under his care, which is a tremendous achievement. Ladies and gentlemen, I am a Mangalore is honored to felicitate Dr. Suresh Rao and his organization.
Dr. Narayan Naik and Dr. Bhaskar Shetty, my senior colleagues Dr. Aital and Saran Pujari, who took special interest in asking MIO to have a CME here, incoming office bearers, and my senior colleagues here, Dr. K.R.KINI.ORATION, Devdas and others, family members of IMA also, who have probably come today. It gives me great pleasure that IMA is felicitating me. Compared to many of them, I am a little bit young, but I am still touching 60 now. I will be a senior citizen in another 2 years. So hopefully I will get some government benefit, I don't know. So regarding my achievements in this number of patients, it's nothing on intention that you do these things. It is on you are put in a situation and then you want to treat or no, that is left to you. The burden, whether to take it or no. So generally in any hospital, we treat around 600 to 900 patients on a radiotherapy machine per year. So earlier in Manipal there are only 1 or 2 postgraduates, so your number would be high. You are forced to treat that many patients. And then when I went abroad also, there was only 1 or 2 people there. So I treated around 10,000 patients in Manipal and 3,000 to 4,000 outside. And when I came to Mangalore again, I was alone there. So obviously we are treating 100 patients on the machine per day. And today we have 12 or 14 doctors there for that number, or for 40 patients actually. So unfortunately I was there for whatever reasons, and in MI also we were alone till we have appointed only recently new faculty for us to help us. So it was under that circumstances I reached that big number, which is difficult generally. I am happy that MIO has grown over the period of years. We started with only 7 staff members. Today we are 220. We are happy that we are supporting so many families. Our philosophy in MI is that the patient quality care what we give should be top, and we should not compromise on that. That is the first principle in MI. Second is the doctor should never be told to do free treatment. There is no free service in MI from doctor. Hospital can do free, but the doctor should be made happy, the hospital staff should be happy. And third is the hospital. So we work on that principles, and this has helped us to achieve lot of confidence from the patients. 70 or 60% of our patients are government schemes, which is cashless. And at the same time, we have 30% who are really affordable and who are taking treatment in MIO. Like the immunotherapy that is given in MIO, I think is one of the biggest number in all India. So that many rich patients, affordable patients are coming to MIO. At the same time, most of the poor patients also come to MIO. So this is because we are specialized in oncology. I worked in general hospital. I felt the need for an oncology center because we can put all our focus as administration to oncological care. There is no other reason to start a separate hospital. And generally in MIO we don't want to duplicate any equipment that is there in Mangalore. So if there is some equipment, we would not like to put it again in hospital because it will be wastage of resources for all of us. So we have worked on these principles, and I had a wonderful team. I should thank Dr. Krishna Prasad and Dr. Sanathegde, Jalaluddin Akbar, and so many other investors initially because oncology is a capital intensive project. It requires minimum 25 crores those days. So it was very difficult for us, but people who had trust in us and put small amounts, including so many members, doctor faculties in Mangalore and other non-medical people also. So I would like to thank them so that in our growth they have helped us. So many doctors in Mangalore have supported MIO, have referred patients out of confidence. It's nothing else involved in that, out of pure goodwill to us, and it's a doctor's project which was very difficult to execute because the loans and all, banks are all very tough. It's not like hospital, we can ask concession in a bank. Within 6 months they will take over your house. Within 7 months, if you do, it's the NPA. I never realized this till we started a hospital. I thought it's easy. I thought the bank manager is such friendly to me. So I said, Madam, this month we cannot pay, I'll pay next month. Then she told me the whole procedure. 3 months you don't pay, it will come in the one warning. 5th month it will go to the newspaper. 7th month you are out. So I was shocked that this is the way things work outside the medical field. We are used to giving concession, and that is a norm in hospitals generally, but it's not also in the outside world. In the non-medical area, they are very ruthless, and they will not show any compassion towards us. So we started paying loans in advance. Whatever money we had, out of fear we were paying, and instead of completing in 7 years, we completed the loan in 6 years. We didn't want to burden the patients by increasing the charge. So, but anyway, we are able to manage. Now fortunately we are loan free, so we can sleep peacefully. So it's a big project, and now we have a lot of colleagues with us. And since we started as a senior people, now other members, you have to give chance to others. So that's how we have to progress, because otherwise it's very difficult for doctors to work in stressful conditions. It will affect our health, and generally that will take a toll on everything that we have done. So we have built a team. Now we are in the third layer of the team, we can see. Me, Sanathegde may be around 35 years experience. Now Krishna Prasad is there with 20 years probably, and then Hemant, Kini is there with 8 years. So we already have the 3 layers which are going to take over the MIO and probably grow it further and see that it is successful. So I would like to thank MIO staff who are assembled here, who are now will help us in the post session, dinner, etc. They have been a wonderful team who have helped very well to build MIO, and I should really thank them because they are a part of this growth. So we get the credit, we are the face of it, but I think lots of people have helped us at this path. And one more thing I should tell is, when Durgadas, our PO, told that this IMA meeting we have to host, and he told me that can you host it in Ocean Pearl or some hotel, big hotel. I said no, if IMA hall is giving us permission, we have to hold it there itself. So I think it's a good. And the second thing what he told me was, sir, alcohol cannot be served. I said that's wonderful. I think that's one of the best decisions. It's in IMA Mangalore. I think all over Karnataka, sir, IMA has to follow this. I think it's not difficult for MIO to spend 30,000-40,000. I think anybody can spend. But I think the principle behind this, that not serving alcohol, especially with family, I think it's a wonderful decision. Otherwise, we always go ahead to the drink counter, even I take a drink, and we would leave our family behind somewhere else. So I think this is a wonderful decision, and I hope that IMA in all over the state should follow such kind of good things that IMA Mangalore is doing. I thank again all of you. Thank you one and all. Thank you.
Ladies and gentlemen, as we are all aware, today is the late of K.R.KINI.ORATION, and to deliver the oration, we have with us eminent family physician, Dr. K.R. Pujari. I request Dr. K.R. Pujari to kindly come on to the dais. I would like to introduce Dr. K.R. Pujari. Dr. K.R. Pujari was post-graduation in ophthalmology from JGMC Davangere in 1998. He was trained in Miraj Hospital, Sangli for a year and has now been practicing since 2000 at Bajpayee in Bhavani Clinic, named after his mother. He is married to Ms. Vichalakshi. He has been blessed with 4 children, 3 daughters, Shavya, Pavitra and Pallavi, and son Pavan Raj Shekhar. Ladies and gentlemen, to deliver the oration today on the role of family physician in medical practice in today's world, I give to you Dr. K.R. Pujari. Ladies and gentlemen, on behalf of IMA Mangalore, we would like to felicitate Dr. K.R. Pujari. I call upon the President, Secretary and all the dignitaries on the dais, including the IMA President of Karnataka State Branch, to kindly come forward and do the honors, please.
ಕನ್ನಡವೇ ಸತ್ಯ, ಕನ್ನಡವೇ ನಿತ್ಯ ಎಂಬಂತೆ ಕನ್ನಡಕ್ಕೆ ಗೌರವವನ್ನು ಕೊಡುತ್ತಾ ನಾನು ನನ್ನ ಅನಿಸಿಕೆಗಳನ್ನು ಕನ್ನಡದಲ್ಲಿ ಹೇಳ ಬಯಸ್ತಾ ಇದ್ದೀನಿ. ವೇದಿಕೆಯಲ್ಲಿ ಈಗ ತಾನೇ ಇದ್ದಂತಹ ಎಲ್ಲ ಗೌರವಾನ್ವಿತರು ಕೆಳಗೆ ಆಸೀನರಾಗಿದ್ದಾರೆ. ಅದರಲ್ಲಿ ಹೆಚ್ಚಿನವರು ನನ್ನ ಗುರುಗಳು. ಪ್ರಥಮವಾಗಿ ಎಲ್ಲ ಗುರುಗಳಿಗೆ ವಂದಿಸುತ್ತಾ, ನನ್ನ ಹಲವಾರು ಸಹಪಾಠಿಗಳಿದ್ದಾರೆ ಅವರಿಗೆ ವಂದಿಸುತ್ತಾ, ಹಾಗೂ ನನ್ನ ಕುಟುಂಬ ಸಮೇತ ಬಂದಿದ್ದಾರೆ ಅವರಿಗೂ ವಿಶೇಷವಾಗಿ ನನ್ನ ಮಡದಿಯಾದಂಥ ವಿಶಾಲಾಕ್ಷಿ ಹಾಗೂ ಮಕ್ಕಳೆಲ್ಲರಿಗೂ ವಂದಿಸುತ್ತಾ, ನನ್ನ ತಂದೆ ತಾಯಿಗಳನ್ನು ನೆನೆಯುತ್ತಾ, ಎಲ್ಲರಿಗೂ ಈ ಕುಟುಂಬ ವೈದ್ಯರ ಪರವಾಗಿ IMA ನನ್ನನ್ನು ರೆಕಗ್ನೈಸ್ ಮಾಡಿ ಇಲ್ಲಿ ತಂದು ನಿಲ್ಲಿಸಿದ್ದಕ್ಕಾಗಿ ನಾನು ಪ್ರಥಮವಾಗಿ ಆಭಾರಿಯಾಗಿ ವಂದಿಸ್ತಾ ಇದ್ದೇನೆ. ಅಂದು ಡಾಕ್ಟರ್ ಕಿನಿ ಅವರು ವೃತ್ತಿಯನ್ನ ಹಾರ್ಸ್ ಡ್ರಾನ್ ಜಟ್ಕಾದಲ್ಲಿ ಆರಂಭಿಸಿದರೆ, ಇಂದು ನಾವು ಕುಟುಂಬ ವೈದ್ಯಕೀಯ ಪದ್ಧತಿಯಲ್ಲಿ ರೋಗಿಗಳನ್ನ ಆಲ್ಕೋಹಾಲಿಕ್ ಡ್ರಿವನ್ ವಡ್ಕಾ ಆ್ಯಂಡ್ ಗುಡ್ಕಾದಲ್ಲಿ ಸ್ವಾಗತಿಸಬೇಕಾದಂಥ ಅನಿವಾರ್ಯ ಪರಿಸ್ಥಿತಿ ನಾವು ಇಂದು ಅನುಭವಿಸ್ತಾ ಇದ್ದೇವೆ. ಅಂದು ಸತ್ಯದ ಕಾಲ. ವೈದ್ಯರನ್ನು ದೇವರು ಎಂದು ಸಂಬೋಧಿಸಿದ್ದರು, ನಂಬುತ್ತಿದ್ದರೂ ಕೂಡ. ವೈದ್ಯರನ್ನು ಗುಣದಲ್ಲಿ ಅಳೆಯುತ್ತಿದ್ದರು. ಆದರೆ ಇಂದು ಕಾಲ ಬದಲಾಗಿದೆ. ಪೇಷನ್ಸ್ಗಳಿಗೆ ಅಂದು ಪೇಷನ್ಸ್ ಇತ್ತು, ತಾಳ್ಮೆ ಇತ್ತು. ಆದರೆ ಇಂದು ಅದು ಮಾಯವಾಗಿದೆ. ಇಂದು ವೈದ್ಯರನ್ನ ಹಣದಲ್ಲಿ ಅಳೆಯುತ್ತಾರೆ. ಕಡಿಮೆ ಚಾರ್ಜ್ ತೆಗೆಯುವವರು ಎಡ್ಡೆ ಡಾಕ್ಟರ್, ಯಾರು ಹೆಚ್ಚು ಕನ್ಸಲ್ಟೇಷನ್ ಫೀಸ್ ತಗೊಳ್ತಾರೋ ಅವರು ದೊಡ್ಡ ಡಾಕ್ಟರ್, ಮಲ್ಲ ಡಾಕ್ಟರ್. ನನ್ನ ಜೀವನದಲ್ಲಿ ನಾನು MBBS ಪ್ರಥಮವಾಗಿ ಪಾಸ್ ಆದ ನಂತರ ಒಂದು ಘಟನೆ ನಾನು ಹೇಳಲಿಕ್ಕೆ ಇಷ್ಟಪಡ್ತಾ ಇದ್ದೇನೆ. ಒಂದು 8 ವರ್ಷದ ಮಗು ರಾತ್ರಿಯಲ್ಲಿ ಓದುವಂತಹ ಸಂದರ್ಭದಲ್ಲಿ ಗೋಡೆಯಲ್ಲಿಟ್ಟಂತಹ ಆ ಚಿಮಿನಿ ದೀಪ ಆ ಮಗುವಿನ ದೇಹದ ಮೇಲೆ ಬಿದ್ದು ಇಡೀ ದೇಹ ಸುಟ್ಟು ಹೋಯಿತು. ಮೋರ್ ದೆನ್ 90% ಬರ್ನ್ಸ್. ಒಂದು ಮಂಗಳೂರಿನ ಒಂದು ಪ್ರತಿಷ್ಠಿತ ಆಸ್ಪತ್ರೆಗೆ ದಾಖಲಾಯಿತು. ಇನಿಷಿಯಲ್ ಸ್ಟೇಜಸ್ ಎಲ್ಲ ಆಸ್ಪತ್ರೆಯಲ್ಲಿ ತುಂಬ ಜನ ಬಂದರು, ಸಹಕಾರವನ್ನು ಮಾಡಿದರು. ನಂತರ ಆಸ್ಪತ್ರೆಯಲ್ಲಿ ಹೇಳಿದರು, ನಿಮಗೆ ಈ ಮಗುವನ್ನ ಇನ್ನು ಬಿಕಾಸ್ ಆಫ್ ಕಾಸ್ಟ್ ಎಕ್ಸ್ಪೆಂಡಿಚರ್ ನಿಮಗೆ ಇಲ್ಲಿ ಅಸಾಧ್ಯ, ಮಗುವಿನ ಬದುಕು ಕೂಡ ಅನುಮಾನಾಸ್ಪದ, ಆದ್ದರಿಂದ ಮನೆಗೆ ಕೊಂಡು ಹೋಗಿ. ಇವರು ಮನೆಗೆ ತಂದರು. ನನ್ನ ಎಕ್ಸಾಕ್ಟ್ ನೇಬರ್ ನನಗೆ ಕರೆ ಮಾಡಿದ್ರು. ನಾನು ಆಗ ಇನಿಷಿಯಲ್ ಸ್ಟೇಜಸ್ ಐ ಟು ಹ್ಯಾಡ್ ಅ ಮೋರ್ ಆಫ್ ಎಂಥ್ಯೂಸಿಯಾಸಮ್ ಟು ಟ್ರೀಟ್ ದ ಪೇಷಂಟ್. ನಾನು ಆ ಮಗುವನ್ನು ಡ್ರೆಸ್ಸಿಂಗ್ ಮಾಡಲು ದಿವಸಗಳು ಆರಂಭಿಸಿದಾಗ ಇನಿಷಿಯಲ್ ಸ್ಟೇಜಸ್ ನನಗೆ ಸುತ್ತಮುತ್ತ ಅಲ್ಲಿರುವಂತಹ ಜನರೇ, ನನಗೆ ಶ್ವಾಸ ತೆಗೆಯುವಂಥ ವ್ಯವಸ್ಥೆ ಕೂಡ ಇಲ್ಲ, ಅಷ್ಟು ಜನ ಅಲ್ಲಿ ಇದ್ದರು. ಕಾಲಕ್ರಮೇಣ ಅದು ಮಾಯವಾಯಿತು. ತದನಂತರ ಆ ಮಗುವನ್ನು ನೋಡಲು ಗತಿ ಇಲ್ಲ. ಅಂತಹ ಸಂದರ್ಭದಲ್ಲಿ ನಾನು ಆ 2 ಕೈಯನ್ನು ಮಗುವಿನ 2 ಕೈಯನ್ನು ಬೆಂಚಿ ಕಟ್ಟಿ, ಕಾಲನ್ನು ಬೆಂಚಿ ಕಟ್ಟಿ, ನಾನು 8 ಗಂಟೆಯಿಂದ ಕನಿಷ್ಠ 12 ಗಂಟೆಯ ತನಕ ಅವನ ಎಲ್ಲ ಡ್ರೆಸ್ಸಿಂಗ್ ಮಾಡಿ, ಆ ಮಗು ನನಗೆ ಕೊಟ್ಟಂತಹ ತೊಂದರೆ ಮೂತ್ರವನ್ನು ಕೂಡ ನನ್ನ ಮುಖಕ್ಕೆ ಮಾಡಿದೆ. ಆದಾಗ್ಯೂ ಯಾರೂ ಇಲ್ಲ ಸಂದರ್ಭದಲ್ಲಿ ನಾನು ಆ ಮಗುವಿನ ಸಂಪೂರ್ಣವಾದಂತಹ ಹೊಣೆಗಾರಿಕೆಯನ್ನು ತಗೊಂಡು ಆ ಮಗುವನ್ನು ಇಂದು ಬದುಕಿಸಿದ್ದೇನೆ ಎಂಬಂತಹ ಒಂದು ನನ್ನ ಮನಸ್ಸಿಗೆ ಅತ್ಯಂತ ಸಂತೋಷದಾಯಕ ಅಂತ ವಿಚಾರ. ಕಳೆದ ವರ್ಷ ಆತ ಮದುವೆಯಾಗಿದ್ದಾನೆ, ಫಾರಿನ್ನಲ್ಲಿ ಈಗ ಇದ್ದಾನೆ. ದಿಸ್ ಇಸ್ ದ ಮೋಸ್ಟ್ ಹ್ಯಾಪಿಯೆಸ್ಟ್ ಮೂಮೆಂಟ್ ಇನ್ ಜನರಲ್ ಪ್ರಾಕ್ಟೀಸ್. ದೇ ಹ್ಯಾವ್ ಡನ್ ವಿದೌಟ್ ಎನಿ ಸೆಲ್ಫಿಶ್ನೆಸ್. ದ ಸ್ಯಾಕ್ರಿಫೈಸ್ ವಿಚ್ ಐ ಡನ್ ಇಸ್ ವೆರಿ ವೆರಿ ನನಗೆ ಸ್ಯಾಟಿಸ್ಫ್ಯಾಕ್ಟರಿ. ಕೋವಿಡ್ ಸಂದರ್ಭದಲ್ಲಿ ಬಹುಶಃ ದಕ್ಷಿಣ ಕನ್ನಡ ಜಿಲ್ಲೆ ಅಂತ ಎಲ್ಲ ಎಲ್ಲಿಯೂ ಕೂಡ ರೋಗಿಗಳನ್ನು ಮುಟ್ಟದಂತಹ ಒಂದು ಸ್ಥಿತಿ. ಆದಾಗ್ಯೂ ನಾನು ಹಲವಾರು ಡೆತ್ ಡಿಕ್ಲರೇಷನ್ ಮಾಡಲಿಕ್ಕೆ ರೈನ್ ಕೋಟ್ ಹಾಕಿ, ಗ್ಲೌಸ್ ಹಾಕಿ, ಫೇಸ್ ಮಾಸ್ಕ್ ಹಾಕಿ ಹೋಗ್ತಿದ್ದೆ. ನನ್ನನ್ನು ಹಲವರು ನೋಡಿ ಹೇಳಿದರು, ರೈನ್ ಕೋಟ್ ದಯಪಾರ್ದರನ್ನ ಈತ ಬಸ್ಸದಲ್ಲ ಬರ್ಬೋದು ಅಂತ. ಬಟ್ PPE kit we cannot use because of the cost. Even then, whatever they given or not, that is their choice ಅಂತ ಹೇಳಿ ನಾನು ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡಿದ್ದೇನೆ. ಆ ಒಂದು ಸಂತೃಪ್ತಿ ಕೂಡ ನನಗೆ ಇದೆ. ಕುಟುಂಬ ವೈದ್ಯರು ಆ ಸಂದರ್ಭದಲ್ಲಿ ಸಮಾಜ ಹಾಗೂ ಸರಕಾರದ ಬೆನ್ನೆಲುಬು ನಿಂತಿದೆ. ಆ ಸಂದರ್ಭವನ್ನು ಕೂಡ ಕುಟುಂಬ ವೈದ್ಯರು ಎಲ್ಲರೂ ಮಾಡಿದ್ದಾರೆ ಎಂಬಂತ ನಂಬಿಕೆ ನನ್ನದು. ನನಗೆ 5 ರಿಂದ 8 ನಿಮಿಷ ಮಾತಾಡಬೇಕು ಎಂಬಂತ ಒಂದು ಅವಕಾಶ ನೀಡಲಾಗಿದೆ. ಅದರಿಂದಾಗಿ ನಾನು ಅತ್ಯಂತ ಸೂಕ್ಷ್ಮವಾಗಿ ಶ್ರೀಕೃಷ್ಣ ಪರಮಾತ್ಮ ಭಗವದ್ಗೀತೆಯಲ್ಲಿ ಒಂದು ಶ್ಲೋಕವನ್ನು ಹೇಳ್ತಾನೆ. ನೈನಂ ನೈನಂ ಚಿಂದಂತಿ ಶಸ್ತ್ರಾಣಿ, ನೈನಂ ಚಿಂದಂತಿ ಶಸ್ತ್ರಾಣಿ, ನೈನಂ ದಹತಿ ಪಾವಕ, ನೈನಂ ದಹತಿ ಪಾವಕ, ನ ಚೈನಂ ಕ್ಲೇದಯಂತ್ಯಾಪೋ, ನ ಚೈನಂ ಕ್ಲೇದಯಂತ್ಯಾಪೋ, ನ ಶೋಷಯತಿ ಮಾರುತ, ನ ಶೋಷಯತಿ ಮಾರುತ. ಅಂದ್ರೆ ನೈನ ಅಂದ್ರೆ ಆತ್ಮ. ಆತ್ಮವನ್ನು ಶಸ್ತ್ರಗಳು ಕತ್ತರಿಸಲಾರವು, ಆತ್ಮವನ್ನು ಬೆಂಕಿ ಸುಡಲಾರದು, ಆತ್ಮವನ್ನು ನೀರು ನೆನೆಯಿಸಲಾರದು, ಆತ್ಮವನ್ನು ಗಾಳಿ ಒಣಗಿಸಲಾಗದು. ಅದೇ ರೀತಿಯಲ್ಲಿ ಕುಟುಂಬ ವೈದ್ಯ ಪದ್ಧತಿಯನ್ನ ಯಾವುದೇ ಕಾಲದಲ್ಲೂ ಯಾವತ್ತೂ ನಶಿಸಲು ಈ ಸಮಾಜ ಬಿಡುವುದಿಲ್ಲ ಎಂಬಂತ ನಂಬಿಕೆ ನನ್ನದು. ಯಾಕೆಂದ್ರೆ ಕೇಳಿದ್ರೆ ಕುಟುಂಬ ವೈದ್ಯಕೀಯನೇ ಭವಿಷ್ಯದಲ್ಲಿ ಎಲ್ಲರಿಗೂ ಬೇಗ ಆಗುವಂತ ಒಂದು ವೈದ್ಯಕೀಯ ಪದ್ಧತಿ, ಅದು ನಶಿಸಬಾರದು. ಆಗಬಾರ್ದು ಆದ್ರೆ ನಿಮ್ಮೆಲ್ಲರ ಸಹಕಾರ, ವಿಶೇಷವಾಗಿ ಸೂಪರ್ ಸ್ಪೆಷಾಲಿಸ್ಟ್ ನಿಮ್ಮ ಸಹಕಾರ ಜನರಲ್ ಪ್ರಾಕ್ಟೀಸ್ ಅವರಿಗೆ ಬೇಕು. ಯಾಕಂತ ಕೇಳಿದ್ರೆ ನಾವು ನಿಮಗೆ ರೆಫರ್ ಮಾಡುವಾಗ ನಿಮ್ಮಿಂದ ಅಲ್ಲಿ ಪಾಸಿಟಿವ್ ರೆಸ್ಪಾನ್ಸ್ ಫಾರ್ ದ ಪೇಷಂಟ್ ಆಸ್ ವೆಲ್ ಟುವರ್ಡ್ಸ್ ದ ಡಾಕ್ಟರ್ ಬಂದ್ರೆ ಮಾತ್ರ ಇನ್ನಷ್ಟು ಈ ವೈದ್ಯಕೀಯ ಕುಟುಂಬ ಬದುಕುತ್ತದೆ ಎಂಬಂತ ವಿಚಾರವನ್ನು ಹೇಳುತ್ತಾ ನಾನು ಈ ಸಂದರ್ಭದಲ್ಲಿ ಜಿ ಕೆ ಭಟ್ ನೆನೆಸಲೇಬೇಕು. ನಾನು ಮೊದಲಿಗೆ ಹೇಳಿದೆ, ಸರ್ ನನಗಿಂತ ಸೀನಿಯರ್ಸ್ ಅವರು ಇದ್ದಾರೆ. ಆಗ ಅವ್ರು ಹೇಳಿದ್ರು, ದಾದಶೇಖರ್ ಪೂಜಾರ್ರೆ ಇತ್ತ ದುಮ್ಮು ಎಲ್ಪತ್ತರು ಇತ್ತ ನಲ್ಪೋಡ್ದೆ ಯಾರೆಲ್ಲ ಗ್ಯಾರಂಟಿ ಹೆಚ್ಚಿ ಆಯ್ತಾ ಅವರ ಇದು ಒಪ್ಪಿಲ್ಲ. ಸೊ ಬಿಹಾಫ್ ಆಫ್ FDA, I thank each and everyone, and I thank all of you with saluting my teachers, everybody. Thank you one and all. Jai Kutumba Vaidyakiya ಹಾಗೂ ಜೈ ಕುಟುಂಬ ವೈದ್ಯಕೀಯ ಕುಟುಂಬಗಳು ಕೂಡ ಆದಷ್ಟು ಇನ್ನಷ್ಟು ಬರಲಿ ಎಂದು ದೇವರಲ್ಲಿ ಪ್ರಾರ್ಥನೆಯನ್ನು ಮಾಡುತ್ತಾ ನನ್ನನ್ನು ರೆಕಗ್ನಿಷನ್ ಮಾಡಿದಂತ ನಿಮಗೆಲ್ಲರಿಗೂ ಹೃದಯಾಂತರದಿಂದ ನಮಸ್ಕರಿಸ್ತಾ ಇದ್ದೇನೆ. ಜೈ ಹಿಂದ್, ಜೈ ಕರ್ನಾಟಕ.
I think I can understand that already it's been a lot of time and effort into this program. So like Dr. Suresh Rao said, we would like to introduce you to the next generation of oncologists here. So first I'll introduce Dr. Hemant Kumar. Hemant is a medical oncologist who has joined us since February this year. He is very dedicated to his field, and I think his thought process in treating patients with compassion is extremely important. So I think without further ado, we can start the program. Hemant will be talking about medical oncology practice, how it has changed from when I started practicing to now how he is practicing. And then we have a radiation oncologist, Dr. K.R.KINI. He is going to talk about some basic aspects of radiation oncology. And then we have Dr. Yashasvi. He is a nuclear medicine consultant who will talk about how PET-CT has really changed the way we practice oncology. So, Dr. Hemant, please.
I call upon Dr. Madhusudan to kindly come forward and welcome Dr.
Most of them being my teachers. I did my MBBS from CME Mangalore, and I had the opportunity to learn under the best of the teachers. So what I'm going to do is going to discuss how probably we would have treated these cancers 10 to 20 years past, probably when Dr. Krishna Prasad started practicing here. And from him he's been my teacher as well, and I've known how things were then and how things have changed. So I'll have 3 cases, quick cases discussion. So this is a 55-year-old lady who had presented as carcinoma right breast in the year 2018. She had a very early stage disease, hormone positive, started on hormone therapy. 3 years later she presented with cough, and on evaluation we found that she had multiple pulmonary metastases, almost around 16 in bilateral lungs. No bone or liver mets. Biopsy was still suggestive of metastatic carcinoma, and hormone receptor was still positive. So she had a ER positive disease after 3 years. What would have been done 20 years back? Chemotherapy was a mainstay of treatment. Associated toxicity, alopecia, sustainability issues of continuing the treatment, families not willing to take chemotherapy. Other option would be probably switch off hormone therapy to either tamoxifen and anastrozole, which was available then, or fulvestrant, which came out later. And what would have been the survival? We would have thought probably 6 months, 1 year, 1.5 years maybe. Now, for hormone positive metastatic breast cancer, the treatment of choice is a hormonal agent along with what is called a CDK4/6 inhibitor like palbociclib, ribociclib or abemaciclib. With this is being an oral combination, they tend to have extremely good responses which are sustained. So this patient was initiated on abemaciclib plus fulvestrant in January 2022, clinically well since last 9 months, and the PET done and the CT comparison, you can see those liver mets have disappeared. PET-CT is actually in complete remission now. Now, why is this important? Because the hormone receptor positive metastatic breast cancer, the standard of care now is CDK4/6 inhibitor hormone therapy. Extremely good responses, sustained responses, minimal toxicity. Patients don't have any major toxicity, no alopecia, that is the most important thing for a lady with breast cancer, and it's an oral therapy which the patient can take at home. More importantly, the survival has changed drastically. With the availability of these agents, probably what would have been survival in metastatic breast cancer of 2 years maybe at max, 2.5 or 3 years maybe at max, it is crossing almost 5 years easily. So this has changed significantly in the terms of metastatic breast cancer. When I look at early breast cancer, this is a 58-year-old lady who had presented with right breast mass of 3 months duration. Biopsy was positive. She was ERPR negative disease and HER2 positive disease. HER2 positive disease is considered as an aggressive biology disease. On clinical examination, it was a T2N1, probably would have thought this is an early stage disease. However, in a HER2 positive disease, we try to get a PET CT done when feasible. Why? Because the possibility of having the upstage in the disease is pretty common. So she had a 2.6 centimeter primary, 3.1 centimeter axillary node, large axillary node, and she had a 1.3 centimeter same side supraclavicular node. Remember, in CA breast, the ipsilateral supraclavicular node doesn't make it a metastatic node, but it upstages the nodal disease to N3C. Now, then there was no availability of PET CT, or probably it was in the very early stages. The accuracy of staging would have been probably questioned. A T2N1 disease, I would have definitely proceeded with surgery then. Neoadjuvant chemotherapy started coming then. However, trastuzumab was one of the earliest targeted therapy in breast cancer, where the role was proven in adjuvant setting, but it was pretty expensive. We decided to proceed with neoadjuvant chemotherapy, a combination of docetaxel, carboplatin and 2 targeted agents, trastuzumab and pertuzumab, both work against the HER2. 6 cycles, excellent clinical response, we could not feel the axillary node. We did a PET CT, absolutely no disease. The disease had disappeared on PET CT, but remember, even despite this, there is a possibility of microscopic disease. We proceeded with radical mastectomy, there was complete pathological response. And in the current era, this is what we aim for. Whenever feasible, we would like to have a complete pathological response, because especially in triple negative and HER2 positive breast cancers, there is a drastic difference in the survival in somebody who has achieved a pathological complete response. So how have we changed the practice now? We try to proceed with PET CT when feasible, because we have the accuracy of staging. Neoadjuvant therapy, because triple negative and HER2 positive respond extremely well to chemotherapy and targeted therapy. Focus on organ preservation is more. Breast conservation surgery is now very easily feasible. In many cases it is possible, and the survival is no different from somebody who has undergone a radical mastectomy. So breast conservation surgery is offered as and when possible, and based on the response, in case somebody has responded very well, we can de-escalate the treatment, and somebody who has not responded well, there is an opportunity to escalate the treatment to improve the outcome. The last case being that of a carcinoma lung, extremely common that we see. 72-year-old gentleman, non-smoker, diabetic hypertension, but with CKD, creatinine of 2.4. He presented with 1 episode of seizure and unsteadiness of gait, evaluated, had a brain metastasis. So this was the initial PET scan. PET is not a very good modality to pick up brain mets. This is CT had picked it up, but the primary was pretty small. It was next to the main bronchus, but on bronchoscopy there is no intraluminal growth. What was the worry then? How to get a tissue diagnosis in this case? You have 2 small brain lesions, nodal disease next to the bronchus, however on bronchoscopy it is clean. Establish a tissue diagnosis, probably mediastinoscopy or any other way. Whole brain RT would have been the direct straightforward treatment option in this case, then probably the chemotherapy. Survival would have been extremely dismal, because somebody with brain metastasis, the 2-year survival would have been 5 to 10%. So that was the situation then. What now? We got a EBUS guided FNA, endoscopic bronchial ultrasound guided FNA. It was proven as metastatic carcinoma, however a biopsy sample was not taken and we did not have tissue for further diagnosis. In the current era, biopsy and IHC is almost always mandatory for confirmation of a diagnosis. What did we do? We were more interested because this patient was a non-smoker, and somebody who is a non-smoker, mutation in lung cancer are pretty common. It can be range up to 25 to 40%. That is nearly 1 in 2. So we took a blood sample, what is called a liquid biopsy, assessed in case this mutation is there, and he had a mutation positive, what is called a EGFR mutation positive. Now why is this interesting? We offered him radiation, we could have offered him SRT, but he chose to proceed with whole brain radiation. EGFR mutation was positive, started on a drug called gefitinib. Post 6 months PET CT done, and remember this is drug, oncology, the moment we tell oncology we always think it's really expensive treatment. No, this is something that is available under Ayushman scheme. 6 months later, this was the previous scan, and there is absolutely no disease. These patients tend to respond very well to treatment, and this is how we treat lung cancer now. The moment a diagnosis of lung cancer is made, the next step is to try and assess what mutation this patient possibly have. Because most of these are targeted therapies, treatment, the response is extremely good in these cases. In case there are no mutation, we check what is called PD-L1 score. This is a score to assess in case what is the possibility of response to immunotherapy, because that is the next big thing in oncology. And this is how the treatment has changed. We probably had 2-3 initial chemotherapy options, and now we do not talk of chemotherapy upfront in lung cancer. And why is, and the other way is to look at liquid biopsies whenever tissue sample is not there, because currently the main area of interest is therapy selection in these patients. Now why is this interesting? So this is EGFR positive lung cancer, where your median survival, that is 50% of the patients are still surviving after around 38 months, that is more than 3 years. With immunotherapy we discussed a 5-year survival of 30%, that is 1 in 3 patients surviving. This particular subset, like this patient had brain metastasis, so there is a subset of lung cancer patients who tend to present with brain metastasis, and in case they have a mutation called ALK, the possibility of response to first line treatment at 36 months is more than 65%. So the whole treatment aspects in lung cancer is changing. To conclude, diagnosis, we have better modalities of staging. PET CT is definitely a boon for us. We do not diagnose on FNA and then treat on FNA. We usually try to get a biopsy, and IHC is almost always mandatory. Liquid biopsy is something that is feasible to try and assess for mutation testing, and more so the target treatment is changing to molecular marker based practice. Organ preservation wherever feasible, breast conservation surgery, rectum surgeries, minimal access surgery especially for prostate, radical prostatectomy, ovarian malignancies, fertility preservation surgery is something that is routinely practiced. Survival has improved. Why? Because we are in the era of precision medicine, trying to target particular molecular pathways and treat that way. Multiple lines of therapy that is feasible. Try to identify a sequencing strategy on how to keep these patients, even with metastatic cancer, live long with a good quality of life. And more so, the treatment is multimodality. The team works as a radiation oncologist, surgical oncologist, medical oncologist, pathologist, radiologist. We always work together to improve the survival. And more so, quality of life is increasing. Chemotherapy definitely has its own toxicity. We have drugs with much better toxicity profile. Oral or subcutaneous forms are available. Better understanding for the patients on the treatment aspect, because on the net everything is available free. Everything is available on an easier access, and better palliative care. Before I conclude, this is one graph which probably inspired me heavily in oncology. Now, CML is something which showed us that we can manage patients with cancer differently. CML had a prognosis of 2 to 5 years in the past. So in year 2000, they launched this drug called imatinib, which is a targeted therapy, the first targeted therapy approved in oncology as such that one will ever see in their life. This is more than 60,000 patients treated with this drug, imatinib, for CML. And at the end of 10 years, you can still see that more than 80% of the patients are still surviving with a very good quality of life. So this showed us the way how probably we have to change our path. And always in oncology, we tell that we have a long way to go, but more so we need to remember that we have come a long.
If the family physician is informed about this, and if he has an unclear understanding that there will be a few patients who will do well, the patients tend to come back to us for treatment once they have consulted their family physician. So I think the reverse is also very, very much true, because we have seen patients even on a ventilator see a lung stage 4, come out of it and survive. We have a young lady who is now I think 6-7 years, brain metastasis, sir has radiated her. Patient was on ventilator when Dr. Akbar did a biopsy of the lung. So she had a ALK positive disease and she is still alive. She is in Dubai with her kids. So I think we have come a long way, but clearly Hemant has put it across that we have not reached our goal. Dr. Kini, I think Dr. Jatana said he likes his classmates, so Kini is also his classmate during his post-graduation. He's done MBBS in KMC Mangalore, MD in Father Muller's. Then he worked as senior resident in AJ Hospital. He is a wonderful addition to MIO, a very empathetic doctor with a clear understanding of radiation. Kini, please, on radiation oncology.
Long way from last 20 years. Thank you.
Radiation, everyone knows there is a radiation as a part of oncology treatment, but what exactly we do here, many of them don't have an idea. Just like how Krishna Brother sir was telling, like some of the patients are really scared to come for radiation. Even today I had a couple of them who are like, they just don't want this treatment. So the role of general practitioners, family physicians will have a big impact, because the fear in the patients can be removed by family doctors, because they trust you more than us. So I'll just brief you about what we do in radiation therapy. So the overview of what I'm talking, firstly what is radiation therapy, then the types of radiation therapy, role of radiation therapy in various malignancies, the side effects, and some of the myth busters. Firstly, what is radiation therapy? The myth is it is current treatment, shock treatment. This is what most of my patients think when they enter my chamber. ನಮಗೆ ಇದೊಂದು ಕರೆಂಟ್ ಒಂದು ಬೇಡ, ಇದು ಯಾಕೆ ಬೇಕು, ಇಂಜೆಕ್ಷನ್ಸ್ ಇಲ್ವಾ, ಸರ್ಜರಿ ಆಗೋದಿಲ್ವಾ? But this is not what we do. The fact is we treat using ionizing radiation. You can see the patient is sleeping peacefully on the machine and it rotates, something like a CT scan. And what is this ionizing radiation? I told we treat with ionizing radiation. So this ionizing radiation is a part of the light. It is something beyond the visible spectra. And you can see the UV rays which come from the sun, that is also an ionizing radiation, and that can cause skin malignancies. Similarly, X-ray machines, they also have ionizing radiation, CT scan with slightly higher energy, and then our therapy machines, they have even more higher energy. And then the other myth about the various cell phones and all that, are they ionizing radiation? No, the radiation from cell phones are not ionizing radiation. Otherwise you could treat by just keeping mobile next to the patient. They are non-ionizing, but will they cause cancer? As of now, there is no proven data for that. In future, we don't know what the studies will come out with. So types of radiation therapy. Teletherapy or external radiation, this is the most commonly used, and whenever we talk about radiation treatment, this is what we generally refer to. External beams of radiation are used for targeting the cancer, and this is used in treatment of almost all the malignancies that we come across. And the next type is brachytherapy. In brachytherapy, the source is placed into or near to the cancer. Commonly used in cervical cancer, head and neck cancer, and soft tissue sarcomas. Now this external beam radiation therapy, you can see here, this is just a small video. There is no actually that red light, what you're seeing is just to dip it, otherwise it's a colorless rays that are coming out. So the machine will be rotating around and radiation is delivered in various direction. So the treatment will take about maybe 15 to 20 minutes maximum, and then the patient is out. And evolution of radiation therapy, because most of the doctors have this concept, like non-oncological radiation, but that is more so common in the older machines than the newer ones. In this picture, you can see the black color is a tumor. And for the reference, there is something called as a sensitive organ. It can be anything. It can be the brain, spinal cord, or the eye. Previous treatment was with a 2D technique, where you can see it's like an outer box. This box which is there, that was a previous technique. Like entire thing, whatever is inside the box is treated. Doesn't matter whether it is sensitive tissue or the tumor. So everything would have the side effects. Then came the advancement of 3D treatment, where it was taking some shape, and some of the surrounding tissue could be spared. Still the tumor and close by organs are getting almost the same dose. And the latest technique, it is IMRT or intensity modulated radiation. Here it is very much conformal, that is it takes pregnancies like nasopharyngeal cancer, where we give a very high dose of radiation and it is very close to eye, still we can spare the eye. So that is what we do with radiation in the modern era. And next briefly about brachytherapy. This is how the brachytherapy machine looks like. It is a portable small machine, and in the second half of the picture you can see there are some cables. So this is actually a gynec malignancy which is being treated. So from this machine those cables are connected to the patient,
and via that the radioactive material will travel and the treatment is delivered. Role of radiation therapy is always there in definitive treatment, where it is the only treatment required. In adjuvant, that is following surgery or chemo. As a neoadjuvant, that is prior to any surgery. And as a palliation. Palliation role is in pain management or bleeding or any other pressure symptoms because of the tumor. And definitive treatment, I will not go in detail. It's mainly in head and neck early malignancies, cervical cancer and lung cancer, esophageal cancer, anal canal, prostate, bladder cancers. Here, radiation alone may be sufficient in the entire cure. Adjuvant treatment in any tumor which is slightly advanced, single modality is not going to cure. So, commonly we see in breast cancer, endometrial cancer, head and neck locally advanced tumors, gastric cancer, lymphomas or CNS tumors, adjuvant radiation is being given. Neoadjuvant in some cases like rectal cancer, sarcoma, and again in locally advanced head and neck, sometimes we give neoadjuvant treatment. Palliation, as I mentioned, role is not in all the malignancies, all the sites, but more common in bone metastasis, brain metastasis, and in case of bleeding, like let's say advanced CS cervix or any hemoptysis or hematemesis, spinal cord compression, and uncontrolled pain because of pressure symptoms or tumor. Then side effects. Myth about side effects, it's very painful. Radiation ಮಾಡುವಾಗ ನೋವು ಆಗ್ತದ? That is a common thing people ask. No, there is no pain while giving treatment. And does it cause burns? Again, there are no burns. So, what are the side effects that we see? First of all, it's a painless treatment as I told. And there are skin reactions. The skin reaction will depend upon which area we are treating. If we are treating the head and neck side, the side effects will not be seen in the rest of the body. It's only to that area. So the reactions may be like just skin color changes, sometimes dryness, or there can be some superficial peeling off of the skin. And then mucositis. This mucositis, again, it depends on the area. It can be in head and neck, or it can be in the GI, or anywhere that we are treating. Xerostomia, yes, in head and neck malignancies, xerostomia was the main culprit. So patients post-radiation had a lot of dryness, but with the present era, that also is very minimal, and we can spare the parotids. Fibrosis, this is a long-term complication that we see, that is somehow not totally eradicated even with the modern era. There will be some amount of fibrosis no matter whichever technique we use. And hair loss is not diffuse, again it is only in the treatment area. Then finally some of the myth busters. Many of you may have the doubt. I have put some of the common questions which my patients or some of my other colleagues ask me. Are family members exposed to radiation after treatment? No. Is radiation therapy painful? As I told a couple of times before, no. It is not painful, and in fact it is used in treatment of cancer pain. And radiation therapy causes nausea and vomiting. Yes, it is site dependent. It is more in case if you are treating the abdomen, and also in some of the CNS malignancies, they can have nausea and vomiting, but not in other sites. Radiation therapy increases the chance of getting cancer. This again is one of the things. Some of the people Google about radiation before they come to us, and they say, Doctor, radiation ಮಾಡಿದ್ರೆ cancer ಬರ್ತಲ್ಲ, ಯಾಕೆ ಮಾಡಬೇಕು? The chance of second cancer is about 1 to 5%, and that is seen about after 15 to 20 years. Now, if you start looking at the survival of the patient, so if the patient can survive for 15 to 20 years post-treatment, I think that itself is great. So, second malignancy should not be the first priority when you're treating. That may be one of the last. If you can survive for that long, yes, we have done a good job. And radiation therapy is needed for all cancer patients? No, it is not necessary. Sometimes it may be sufficient to just go forward with the surgery, and that will be curative. And radiation therapy is always given with chemo? No. Concurrent chemotherapy is given in most of the cases, but it is not a hard and fast rule that always chemo has to be given. And some more of those. Whole body is exposed to radiation during treatment? No. As I was showing, with the modern technique, only the tumor can be targeted, even the adjacent organ also can be spared. And the next question which many of my patients ask, radiation therapy ಅಂದ್ರೆ ಉಷ್ಣ ಆಗ್ತದ? Is it heat and ಅದಕ್ಕೆ ಅಂದ್ರೆ ತಂಪು ಮಾಡಬೇಕಾ? No, radiation therapy is not ಉಷ್ಣ. Whatever reactions that ಉಷ್ಣ they depict, it is basically the mucositis that they are talking about. So no treatment is required for this radiation ಉಷ್ಣ. And there is no role of radiation therapy after complete removal of tumor. So this question I frequently come across when breast cancer patients come to me. They first undergo surgery, then they have some 6 to 8 cycles of chemo, and finally when they think everything is over, they are referred to us, telling next thing on the radiation beku. So they ask, like, I have no tumor and also underwent chemo. Is it required? Yes. There is role of radiation in spite of the entire tumor being removed and even if they have received chemo, because each of the treatment modality have their own role to play in curing cancer. To summarize my entire talk, radiation therapy is a painless modality of treating cancer with ionizing radiation. It can be used to cure cancer either alone or along with surgery and chemotherapy. Radiation therapy can be used for palliation of pain, bleeding and pressure symptoms. Thank you.
Thanks, Kini, for that talk on radiation. It is a small percentage, it's not a big percentage, but a small percentage of patients who go into complete remission. I think Dr. Yashasvi will show you some PET scans where they go into complete remission, and in fact in some of them you can avoid a colostomy, you can avoid a surgery itself. This is not a big percentage. All patients with low rectal cancers always underwent surgery. Now this is not the case. So I think radiation has come a long way, and now we recognize where it can really help in treating patients. Yashasvi is our consultant in nuclear medicine. He's done his MBBS and MD from the prestigious Jipmer Medical College in Pondicherry. He was working as an assistant professor in Manipal KMC, and he has joined Mangalore Institute of Oncology. So he will talk about role of PET CT in oncology. Just like the previous two speakers, he will be short and very sweet.
Thank you, Dr. Pradeep Sedapati.
Going through the basic scans or even sensitivity, specificity, etc., I'll show what is the role of PET CT in and impact of PET CT on management of patients in oncology. Okay. So we'll see what is PET CT, what is the mechanism of action and applications of PET CT PET stands for positron emission tomography. For this purpose, we use radioactive elements which will emit positrons, which are positively charged electrons, which will eventually be picked up by the scanner, and the images are reconstructed and we can view the images. This is a PET CT scanner. It's in hybrid imaging, PET as well as CT. So there are two rings in the gantry behind. This is the gantry, this is where the patient will lie down. So in one go, we can take acquire PET as well as CT scans, fuse them and then review the images. We call it a tracer, not a contrast. In nuclear medicine, we call it a tracer because it traces the physiological process in the body, like glucose metabolism for fluorodeoxyglucose, and prostate membrane antigens will be targeted by PSMA, as well as serotonin receptors by DOTA agents. So major mainstream is F18. All of you already know FDG. That is a mainstream. There is also gallium-68, gallium PSMA, etc. There are other traces also which are used for other purposes, more in the research and academic orientations. So this is, I think all of you will recognize this one. This is essentially an MIP image of a PET, maximum intensity projection. Here you can see brain uptake, heart uptake, some mild diffuse liver uptake is there, and urinary bladder distribution is also there. This is physiological. And you can see compared to the previous one, there are dark spots here. That is the malignant or infective or inflammatory uptake of PET. So applications for staging, it's pretty straightforward. Primary and local infiltration, lymph nodal and distant metastasis. That we won't see much. It will be useful for restaging, response assessment, and more importantly, treatment modification. This is just to show you the value of PET CT. In lungs here, you can see the high sensitivity and specificities of FDG. Essentially, it will be similar in all other scans, because all other cancers, because all the tumors are glucose hungry, so they will take up more FDG. This is a pretty straightforward case of CA breast. Patient presented with complaints of swelling in the left breast, increasing over the past few months, and biopsy was done. This is how it will look on the PET CT image. You can see the increased uptake of FDG in the lesion. It's rather a multifocal lesion. Two lesions are there with axillary lymph node metastasis. Now, more importantly, there is recently we have something called as PET guided biopsy, and its advantages over standalone CT we can see here. This is a case of CA lung. We can see the increased FDG uptake here surrounded by non-FDG with consolidative changes in the lung. So essentially, if you can see just the CT image, it all looks fairly similar. So for example, if instead of going for the biopsy in this area, looking at the CT, if we had gone in this or in any other area, we would get a negative result. So this way PET CT will be useful for guiding the biopsy. Not just CA lung, for example in a case of lymphoma also, if there is a high uptake will be there in some of the nodes, low uptake will be there in some of the nodes, we can see in the scan and I can suggest the oncologist like where to get the biopsy from, which might turn out to be mostly a positive result. And this is another case. CA breast, it's post-operative case, post-chemotherapy, radiotherapy, everything was done. Patient came with a back pain. Patient has a multiple lesions, metastatic lesions in the spine, vertebral column. Of course, there are multiple sclerotic lesions also. But here, what I want to show you is there is increased uptake in the bone marrow because on CT image, there is no uptake at all. There is no anatomical lesions at all. But however, on PET CT, we can see increased uptake. So this is one of the other advantages. And this is a case of any solitary pulmonary nodule. You all know that solitary pulmonary nodule, depending on the size of the nodule, the chance of malignancy will differ. However, if there is increased FDG uptake, it is highly likely that lesion is metastatic. FDG has around 91% sensitivity in solitary pulmonary nodules. And for it's useful for restaging also. This is pretty straightforward. This was a 78-year-old male, known case of CA lung. This is the first scan before chemotherapy and radiotherapy. This is a primary lesion. You can see the consolidation, which is obstructing the bronchus and causing consolidation in the lung. We have taken a follow-up scan for this patient. These are all actually very recent scans. In this, we can see in this area of consolidation is actually reduced because the primary in the site has come down. But however, the patient has multiple other new lesions were there, which were not seen in the previous scan. Even there is a paratracheal lymph node. This is a small pleural lesion. I actually should have included the CT in the sagittal section to show how, it's just over the diaphragm. So if you just see the CT alone, we might not have picked up. But on here, we can see the FDG uptake. Of course, there are lesions at other sites, so it is metastatic. But even then, FDG helps in this diagnosis. And it also, PET CT also has a role in guiding the treatment and looking beyond just the loco-regional disease. Traditionally, when we take a CT image, we usually take a regional image. For example, this is a case of CA rectum with a loco-regional infiltration is there. This patient was planned for radiation therapy. But however, on PET CT, we have found it's nearly a centimeter sized node showing a faintly increased FDG uptake. So we had a suspicion of metastasis, and FNAC actually turned out to be positive in this case. Here we wouldn't expect metastasis to cervical lymph node in a case of CA rectum. But PET CT helps because in PET we have seen the MIP images before. It will cover from head to mid thigh. Here we can see from head to mid thigh. This is a routine PET CT we do. For example, in multiple myeloma case and any other bone malignancies, we take till toe, head to toe. So essentially, when I see the images, I will see it through the entire body. And any small lesion, I will want to rule out malignancy in that. If traditionally, if we had taken only the CTs of regional areas, we might have missed the cervical lymph node. And PET CT, of course, response assessment, essentially you'll do a scan before, give the treatment, and do a scan later, see how the patient responded. That is that's straightforward anyway. This is a case of lymphoma. Previously, there were mediastinal nodes, increased uptake in the spleen, some gastrohepatic nodes, retroperitoneal mass lesion is there. However, this is actually an interim PET CT. In response assessment, we have two types. One is interim, one is end of treatment. Interim is between the chemotherapy cycles, we can do a PET CT and see whether the patient is responding or the treatment is not working, whether the disease is increasing. And end of treatment is essentially after the entire treatment is over, we can just do the PET scan and see how the disease is. So in this case, like Krishna sir was telling, there is complete response. There is no retroperitoneal mass lesion also. So if we might have planned for any adjuvant radiotherapy in this patient, now that is not required. We can avoid that. This is just a table, will not go through the details. This is just a universally standardized criteria to see the response in the lymphoma patients. We just give a scoring to see whether how much amount of disease is present. And this patient, actually we were discussing with Hemant sir recently. One case of colorectal cancer, the patient was on bleomycin, and when the PET-CT report was done, Dr. Hemant called me, and we were wondering if this could be because of the pulmonary toxicity by bleomycin. He has counseled the patient, and we were on a lookout for any development of symptoms. Patient was, I think, mildly symptomatic that time. And anyway, eventually the patient called and he told the symptoms are increasing. So he has stopped bleomycin and changed the chemotherapy course, and the patient symptoms also have improved. So it's not just the malignancy and response alone. We can see multiple other aspects and improve the standard of our care. And this is another case of CA rectum post chemoradiation therapy. Here we can see this is the first column is the previous before treatment. Anterior wall we can see increased uptake. We can see enhancing thickening is there, but however it has completely disappeared. There is only very subtle thickening and non-enhancing and non-active, means there is no FTG uptake, which means it is not metabolically active. So these are the cases where we can avoid invasive surgeries and keep the patient on close follow-up. This is another just PET evaluation response criteria in solid tumors. We will just see the left column of it. So for complete metabolic response, we have seen before, like lymphoma or even CA rectum, we can avoid unnecessary invasive or extra procedures. For partial metabolic response, like for example in an interim PET-CT or something, where the patient is responding, then we know the chemotherapy is working. So we can go ahead with the chemotherapy without changing the regimen. Progressive disease is essentially which is not responding, which is actually increasing. So they might have to go for a stronger chemotherapy regimen. And stable metabolic disease, the name says there is no progression or regression, and the treatment decision can be taken accordingly. And finally, these are the other tracers. For prostate CA, there is PSMA scan we can do. In our MIO, we are doing F18 PSMA scan. We are getting the source from Bangalore, but we are planning to get a gallium generator. Essentially, from that we can produce the tracer, which I was talking about, which we can inject the patient directly. We can have an in-house preparation of that, and we can inject the patient and take the scan. This second one is the FDG PET, and the first one is F18 or even gallium-18 PSMA scan. You can see the number of lesions here are more numerous, very high compared to the first one. So you can see how much more sensitive it is in prostate CS, PSMA, rather than just the FDG. We are seeing FDG uptake even here. Those are aggressive lesions, which are even, they take up even glucose, of course, like that. And something else like DOTA, if this is a case of carcinoid in the left lung, 37-year-old female. First one is an FDG PET-CT. We are not seeing lesion actually, there is no uptake. It's well differentiated carcinoid, which is showing very high gallium DOTA uptake, DOTA knock uptake. And this is one example of the theranostics where we can therapy as well as diagnostic procedure can be fused. For example, lutetium dotatate therapy in cases of metastatic NET. So the first is a gallium dotatate PET scan. Because of the higher resolution we can tell. There are multiple lesions, and we have to look at the fact that all the lesions are actually showing good uptake, which means the tumor metastatic lesions have good affinity for the DOTA, DOTA agent. So we can give a lutetium is a therapeutic agent, beta emitter. We can give lutetium dotatate as a therapy to the patient, which will systematically clear off all the cancer cells, not clear off, reduce the disease burden. Similarly, there is a lutetium EDTMP therapy also. For that we can do this basic bone scan, we can do technetium MDP scan. We can see the affinity, and then we can give the lutetium therapy also for bone pain palliation like that.
All the dignitaries on the who were on the dais to kindly come back onto the dais, please.
Sir, and all the dignitaries on the dais and respected members of IMA, and also from IMA Kasaragod. Thank you very much for appointing me as election officer. With this, I am not present in the next team as as a working committee member, but I will be always there in IMA for that, Dr. Venugopal. President for 22 and 23 will be Dr. Venugopal. Secretary, Dr. Archit Bola. Where we will be having a dynamic year, and Treasurer, Dr. Nandakishore B. Joint Secretary, Dr. Alam Nawaz, Public Relation Officer, Dr. G.K. Bhatt, Sankapitlu. President, Vice President, Dr. Manohar G. Revankar, and Dr. Harish Rao A. And Editor, Dr. Devdas Rai B. Internal Auditor, Dr. Jerome Pinto. Historian, Dr. Mukund K. And there are 31 state council members who have elected unopposed, and I request all of them to come to the inaugural thing. And I am not reading the names. President-elect Dr. Ranjan Rao K. Today World Anesthesia Day, so we wish all the anesthetists happy Anesthesia Day. And Dr. Ranjan is anesthetist, and Central Committee Council members are 16, and once again I request all of them to come for the meeting, next meeting, and also alternate Central Council members are 16. So all will be together. There will be 81 members in the team next year, and not to forget, ex-officio members will be Dr. Satyamurthy Aital, Dr. Sadanand Pujari, and IMA Trust President Dr. Divakar Rao A, and Secretary Dr. Sachidanand Rai B. He was there, and members from IMA to IMA Trust Dr. Rajesh Balan and Dr. Roshan Shetty. So that's about the team. I have not read the members because I am expecting them as well as for the time shortage. And I have one more task about the IMA state with the IMA Karkala hosting, because IMA Karkala is very close to us as well as Udupi. So all of us together hosting the IMA conference in Mudbidre. President of IMA KSP also requested to request most, because we are always involved in this particular event, requesting all IMA members of Mangalore to register because our registration is quite less. We are requesting many members from IMA Mangalore to register. Registration counter, we will get the details of the registration, as we are involved in even the posters, and a lot of students have registered for the poster and this thing from Mangalore. Thing is, we need a lot of chairmen and judges for those things. Kindly register for the IMA conference at Mudbidre. So that is fine. And one important thing, today IMA trust members are there. Dr. Bhaskar Shetty sir is also there. We request, because IMA trust, there is a message which is drafted by our beloved trustee Dr. Jerome Pinto sir on behalf of all the trustees and the team, which is we are all endorsing. Dr. Divakar Rao sir, Sachidanand Rai, me, as well as Dr. Devadiga sir. That is, dear friends, you know IMA is and IMA building is our home. We all love it and gladly spend our time in it. Since pandemic, IMA building income has dwindled, and so there is no corpus money for the repair. Now this building and this hall requires urgent work of about probable cost of about 15 lakhs. Hence, there is a request to you to donate generously, and this is a request from IMA Executive Committee and IMA Trust. IMA President also joined for this, and this is already we have already collected 2 lakh from the trustees and the important members. We request, we will you can scan a code which will be put in all IMA groups and you can send the money immediately. And we also, there is an announcement that is next installation IMA meeting will be held on, that is on 11th November 2022. That please remember, that's on Friday. Remembering it is easy. 11/11/2022. So many 11s are there. So please remember that and come in big numbers and yeah, that's what, 11 into 2/22. Thank you very much for the opportunity.
Doctors who presented for the CMA today, on behalf of IMA Mangalore, to express the token of our gratitude, I call upon the State President, Dr. Suresh Kodua, to kick off today's program. Dr. Krishna Prasad, Senior Medical Oncologist. Thank you, Dr. Hemant. Now, since you left, you are responsible for handing it over. Thank you, Dr. SSV. Also, thank you, Dr. Suresh Kodua. President, Dr. Satyamurthy Aital, sir, to kindly present the memento to begin with. To our IMA KSB State President, Dr. Suresh Kodua. I call upon the President to present the memento to Dr. B. Narayan Naik, President, IMA Kasaragod Branch. Another guest of honor, Dr. Bhaskar Shetty, Dr. Aital, to present the honor. One of our members who was decorated with the honorary professorship of IMA, that is Dr. Animesh Jain. He was presented with the honor by Mrs. Meenakshi Lekhi, Minister of State, External Affairs and Culture in New Delhi. The Health Minister was also present. I call upon Dr. Suresh Kodua and congratulations, Dr. Animesh Jain.
The announcement, next this November 11th is the installation ceremony. So kindly attend the installation ceremony with large number. Another thing is next year the Somaya Memorial Badminton state level, it has come to Mangalore branch. So it is the great responsibility of the Dr. Venugopal to organize the state level Somaya Memorial Badminton Cup. Okay. And ladies and gentlemen, all the family members of Mangalore branch, it is my proud privilege to propose a vote of thanks for today's Dr. K.R.KINI.ORATION and CME and the annual general body of IMA Mangalore branch. Firstly, I would like to thank our State President, Dr. Suresh Kodua, for attending the program, and he is there from today morning. He visited Karnataka Bank's chairman and also Omega Hospital, City Hospital and Vinaya Nursing Home and all the hotels. He met, I think, land traders owner for the sponsorship and so thank you, sir, for attending, in spite of your busy schedule, attending the Mangalore branch program. And he has attended our installation program also. So I also thank Dr. Bhaskar Shetty. He's a great surgeon, administrator, down to earth. Moreover, he's a great human being. Thank you, sir, for attending our program. And also I would like to thank Dr. Suresh Rao. So Suresh Rao is a team and he believe in teamwork. So last 10th year celebration is. So we attended and he has recognized starting from the attender to staff nurse, office, everything. He gives the success of the MIO to all the staff members. He says he started from 100 to 220. So the teamwork has given the great achievement, has helped MIO to reach the highest level. So thank you, sir, for attending today's program, as well as he has given a wonderful dinner